Hello, I'm Dr. Jeff Donner from Loveland, Colorado. Today I'll be presenting on the technique, pitfalls, and revision strategies using the posterior-inferior approach. These are my disclosures. The objectives today are to review the pertinent anatomy of the posterior-inferior portion of the SI joint, as well as the biomechanical considerations when using that approach, and the available technologies as well as revision strategies. The unique feature of the posterior-inferior approach is it allows direct access to the articular portion of the joint where you can remove the cartilage under direct visualization or indirect and prepare the bony surfaces as we do in traditional orthopedic joint fusions, and we can also add rigid fixation. This is an example of what a CT scan post-fusion of the joint looks like when we follow these principles. On the left-hand side, you can see the trabeculating bone that crosses the joint. Compared to the right side, you can see rigid fixation, as was performed in this case when I started doing the procedure over 20 years ago. And you can see this required some rigid fixation, but over time we were able to narrow down this approach just to the posterior inferior portion of the joint, which I will present as we go along. So the anatomy specific to this, the posterior inferior access point is demonstrated at the level above the sciatic notch, where the articular cartilage is well identified and actually approaches the very back of the joint, which is very convenient for the surgeon, so they can actually be in the joint very quickly. And again, on the right-hand side, you can see that blue cartilage on the inferior portion of the joint above the sciatic notch. Under X-ray, there's the typical view of the lateral sacrum, but you can see that the actual articular portion of the joint extends more anteriorly than you typically see. And this will be better demonstrated on this anatomic model. And you can see the articular cartilage on the lateral view has the red lines on it compared to the extra-articular portion of the joint, which is more dorsal. And again, it's below the PSIS and above the posterior inferior iliac spine or the sciatic notch. Under fluoroscopic guidance, this is how I identified this as a unique opportunity. Since I performed my own injections, I could see I was very close to the joint by placing the needle dorsally and then injecting the contrast, outlining the joint, as you can see on that fluoroscopic image. The CT scan, though, can be very confusing depending on how these axial cuts are obtained, and it makes the joint look very irregular, like this extra-articular portion of the joint where there's ligaments versus the articular portion of the joint, which is more linear, as you can see on the right-hand side on this view. Again, the anatomy looks serpentine in terms of how do you get an implant into this articular portion of the joint, and it is actually a cut that shows in a view that is not true when you actually access the inferior portion, which is much more linear, as I showed on the last CT scan. The important anatomy, as you can see, is very clear with the S1 foramen have to be avoided, and of course there's a large number of vessels and neural structures anteriorly which need to be avoided. There's very robust posterior ligamentous complex that gives the stability of the joint, that when you approach just the articular area in the front, these are not violated and still maintain stability. The other anatomy is well known in the buttock area, but in terms of the inferior portion of the joint, there are some small cluneal nerves that have to be considered. There's a very loose connective tissue where the muscles attach, and the joint capsule, but no major ligaments in this area. There is a sciatic notch in the gluteal vessels that have to be considered, as well as the sciatic nerve, but this nerve is very supple and moves out of the way, and it's not really an issue when approaching the joint below the PSIS. And the vascular anatomy is obviously very important. The superior gluteal artery, nerve, and vein are in the notch, but they're much lower compared to the access point up in this region. And all anatomy for the lateral devices have to be considered, including this vessel, which is less of an issue when you're performing the posterior inferior approach. Again, the very robust neurovascular structures anteriorly need to be avoided as well. The robust ligaments are critical to the SI joint, and they are very stabilizing and allow very little motion of the joint, although there's a lot of contact force across the articular surface, as we know, since it's a keystone joint and all the body weight passes through there, pushing large amount of forces against the bone surfaces. That's why it can be very painful, even though it doesn't move very much. And yet, when you resect these posterior ligaments, Dr. Dahl and his associates were able to show that it has very little effect on the motion. And the posterior inferior portion doesn't even resect any of those interosseous ligaments. So again, this will not cause any destabilization by performing this approach. A lot of companies have now recognized this opportunity, and they are developing technologies in this region. This is a catamaran looking device that has bone windows that traverse the SI joint that are filled with allograft bone or autograft bone within the empty cylinders that have the fenestrations. But again, they do not prepare the joint per se. They just impact that across the joint to get stabilization and fixation on either side of the joint. There are other joint devices that actually do prepare the joint to some degree, but they also use an allograft type of device, which has its limitations. A lot of them do have some windows that allow for autologous bone to be placed, but the problem with these devices is they tend to resorb and fragment. Most of them are not supplemented by internal fixation, but a lot of these have been developed because of the less rigorous regulatory pathway that allows companies to manufacture and market these devices. This is an example of how that's being used, and specifically for patients who are having problems with pain in their SI joint after long fusions, even with iliac fixation. You can see on the right-hand side, there's a instrument that approaches the posterior portion of the SI joint in the inferior region, right above the sciatic notch. It prepares the joint surfaces and allows for impaction of this allograft device in order to obtain a true arthrodesis. And again, this approach is very helpful for diagnosing pain despite internal fixation with fixating devices, non-fusion devices. And once you diagnose it, you have the ability to use that access point to clear out the cartilage, like with this curette under direct visualization, and place bone graft inferiorly. And in this case, there's a peak cervical cage that's filled with autologous bone graft and allograft that is used to stabilize and obtain a true fusion to add further stability and pain relief. Again, this is a direct visualization under a microscope. You can see the articular cartilage between the ilium and the sacrum, and whatever instruments you choose to remove this and to obtain your fusion. This can be done with any of the devices that are out there manufactured that actually are primarily transfixation devices between the ilium and the sacrum versus a true SI arthrodesis, which I believe is the main purpose of performing an SI fusion, not a fixation, but a fusion, and the posterior inferior approach allows for this. Again, this is what it could look like When you obtain the right type of arthrodesis, you can see that joint is eliminated, and I predict that if there's no joint, then it's hard to have pain from a structure that's been obliterated and fused. On the left-hand side of the patient, you can see this can be formed with any of the devices that are being used at this time. And the CT scan again shows what the durable looking fusion we strive for. And you can see that on the prior fusion on the left-hand side, and how that can be added to other devices as a secondary revision type of operation. Thank you for your attention, and I look forward to questions.